Okay, so now before we begin, I want to set a clear expectation for all of us as we're here. This is not just going to be a session where we will simply define terms or repeat what we've already learned in school, what is already in textbooks, okay? What we want to do today is to take you into the real world of laboratory practice. So it's like an introductory session to take you into the real world of laboratory practice, the kind of reality that we face daily, but sometimes we don't usually stop to analyze them deeply, okay? Because the truth is, most laboratory professionals already know what to do. That's the truth. Most of the laboratory professionals already know what to do. The real challenge is not the knowledge. The real challenge is consistency. The real challenge is discipline and understanding the consequence of small decisions that we take in our everyday workflow in the laboratory. Let me start with a question. And I want you to really think about it, not just give a quick answer. So please, I want this session to be really engaging. So whenever I ask a question, we can just drop a message on the chat box, or you can unmute and respond. So I want to ask a quick question. Do you think a laboratory result can be technically correct and still be wrong? It's a question. We can just quickly drop an answer on the chat box, or you can unmute to an answer. If you say yes, you tell us why. If you say no, you also tell us why you're saying no. Can everybody still hear me?
Yes, we can.
Yeah, so please, let's give an answer. I think I'm seeing. Okay, Precious, so I think before we can actually go ahead, let's get to know the people that are on the call. So we've introduced ourselves here at ISN, so let's get to know others so that we can actually engage properly with those of us, those people that are on the call. So I think you can unmute and introduce yourself. Just tell us your name, where you're joining us from, please, before we go ahead. Thank you.
Good morning, everyone.
Good morning.
Good morning.
My name is Dory. I'm joining from Ibadan Central Hospital, located at Ibadan.
You're welcome, Doris. Nice to have you here.
Same here, sir.
Hello, good morning.
Good morning.
Yes, my name is Paul, and I'm joining from BT Health and Diagnostic Center, Ikeja. So I'm part of the IT support team. So I'm here because no knowledge is waste. All right, so that's why I'm here. Thank you.
Thank you.
You're welcome, Mr. Paul.
Hello, good morning. This is Kalifu Ogoshuko-Zama from BT Health and Diagnostic Center.
You're welcome, Uzoma.
Hello, good morning. My name is Aputu Amos from Chevron Hospital, Lagos.
You're welcome, Mr. Amos.
Hello.
So,
Yeah, please, you can just unmute.
Hello, good morning. Can I go ahead?
Yes, please.
Hello, good morning. My name is Nnamdi Pius. I'm Malens Diagnostics, Lagos State. I'm a scientist.
You're welcome, Pius.
Hello, good morning.
Good morning.
My name is Success Winner from God's Grace Diagnostic Lab, Omaya. I'm a scientist.
You're welcome to
Good
this session.
morning. I'm Joy Otwaka from BT HDC.
You're welcome, Joy.
Hello. Good morning, everybody. My name is Oregbeme Patience from Mainland Hospital, Yaba Laboratory.
You're welcome, patient. Nice to have you here. All right, so we don't waste our time. We just go ahead with the session. So
Hello? Hello?
yes, I think someone else is talking. Yes, I can hear you. You can go ahead.
Can you hear me?
Yes, you can.
Can you hear me? Okay, I'm Mr. Marachi Wakam, God's Grace Diagnostics, Umuahia, Abia State.
You're welcome, Mr. Marachi. Nice to have you here.
Good morning.
Good morning.
Good
My
morning.
name
Good
is
morning. Yeah,
Leon
my name is
from Medicare.
You're welcome.
Hello, my name is Akinyele Akinbade from BAM of Gilead Hospital, Elisha.
Thank you, sir.
You're welcome.
So Rufus, you can proceed so that we don't waste anybody's time. You can reiterate your question. Now we have their attention.
Okay, thank you very much. So wanted to use that to actually get your attention. So I actually asked the question. I said, do you think a laboratory result can be technically correct? That is, your results be correct, but still be wrong? It's a yes or a no question. So if you say yes, you tell us why you think is a yes, and if you say no, you tell us why.
Okay. Yes, it can. And why I'm saying yes is because a result can be technically correct and still be wrong at the same time because the machine used in running the tests work properly at the time. The reagents are working fine.
We've lost you.
Okay, sorry. I was saying yes, a result can be technically correct and still be wrong at the same time because the machine that was used in running the sample, it's working properly. The reagents are fine, working fine, and the procedure used in carrying out the test was correct. But the result will still be wrong because of depending on the time the person's sample was taken, depending on the type of test that the person wants to run. Let's say a person wants to run a fasting blood glucose, and then the time of the sample taken, the time when the sample was taken, was not when it was supposed to be taken. So the process of running that test is correct, but the result is going to be wrong because it's no longer a fasting blood glucose that you're going to give the person. So that's why I said yes. I don't know if I made sense there.
Yeah, thank you very much. I think that's winner success, right?
Yes, sir.
Yeah, thank you very much, winner success. That's really a great answer. That's really a great answer. So that is talking about the pre-analytical stage of analysis in the lab, right? So that can actually affect your results. Thank you very much. That's the correct answer. Does anyone have any contrary opinion?
Yes, sir.
There's a
Good morning,
question
sir.
in the chat box, please.
Good morning, sir. I don't know if
Yes.
anybody's hearing me.
Yes, Akimbade, you can go ahead. Yeah, I can hear you.
The result can be right and can still be wrong, in the sense that once a test is run, the test might not get the actual value, but it will get the range of the value of the right value. In the sense that maybe someone on this fasting full blood count, yes, it might not show the actual precise results, but it will tell you that this range, because there are ranges of normal, ranges of abnormal, ranges of so it will give you the actual value that this thing is normal. But if you rerun it again, it will still give you another number, but still it will still tell you that this thing is still at the normal range. And if it's not on the normal range, it will show you that it's not on the normal range. If you run it 2 to 3 times, you will be getting different values, but still all the value will still be on normal range. If it's not normal, if it's abnormal, you still range it at abnormal range. So that's my answer. I don't know, maybe I make sense there.
Yeah, thank you very much, Akimbade. Thank you for that your answer. That's a really great one. Yes, Osinachi, you're raising your hand.
Yes. Good morning, everyone. Can you hear me?
Yes, we can. Go ahead, please.
Okay, yes. My name is Ezalagios Nachi Stanley. Actually joining live from Lagos. I just joined, and by special grace of God, people are really doing well. I still want this opportunity to thank each and every one of you for bringing this particular program, online program. Please, I just want to comment on that particular issue. One thing about this issue of getting good results and bad results is what you put in. As I think is actually what you get. My own suggestion or my own comment there is that whatever you put in is what you get. Because I want to use the example of one of the tests that were conducted in one particular lab. So what happened is that test, it was a HIV. The test was actually expired. When we carry out, we discover that the person who used it to carry out the analysis, when we collect the sample, apply the blood, we discover that it gives positive. Understand? So people begin to wonder what actually is the problem. But at the end, we'll find out why testing the expiring date. Discover this particular script has expired. Do you understand? It has expired. So if something expired, it's actually going to give wrong results. So one, I don't understand if something that is good, although someone has already said something concerning that it can actually give good and bad. But my own is that if that particular sample, anything that they're carrying on is wrong, it's going to get a bad result. I don't know why. I don't know if there's any reason, if there's something concrete reason that something, when you put something good, it can actually get a good result. But although I'm here to learn, that's my own contribution, is that if that test, if you are running a test or anything they are putting in is bad, it's gonna get a bad result. That's my own suggestion.
Okay.
Yeah.
So with respect to this, let me give a practical example.
Yeah. Okay.
You've been managing a patient on diabetes.
Okay.
And normal glucose level is expected to be within 3.5 to 5.5 millimoles per liter. Reference range. But this person, because he's a diabetic patient, we've been managing the person within 8 millimoles per liter. And that person has been stable, no issues. So if you now run that test and you don't get a 5.5, I'm giving you an example. You will say the result is elevated, but that is that person's baseline. You've not looked at, number one, what is the clinical picture of this person? Do you understand? The result is correct, but you are telling it that, no, this result is not correct because you've not interpreted it in context of that person's clinical picture. Do you understand? That's one. Another one is when a wrong sample is collected. You know how we can collect what's it called? Serum sample. We'll now use a syringe, collect it. Instead of dispensing into the serum sample and the full blood count sample, we'll have to dispense into the full blood count sample first. And we'll now dispense in the serum sample container next. Order of draw is very important when we are collecting sample. Inadvertently, you have introduced EDTA into the serum sample. Imagine what happens to the sodium and chloride and potassium of that particular serum sample you want to use to run the electrolyte testing. It will be elevated. Your result is technically correct, but because of the pre-analytical condition, it has invalidated that result. Do you understand what I'm saying?
Yes, ma'am.
So, Rufus, you can go ahead.
Yeah. Thank you very much, everybody. So that's we've all given very great answers, and I'm happy that we understand most of these things. But like I mentioned before, it's not that most of us don't know these things. It's just about consistency and the discipline, and also the how we can actually put them to practice. That is actually affecting most of our laboratories these days. So that's the reason why this webinar was put in place, so that we can actually correct most of these things. So the question, as like I asked, was, it sounds contradictory, right? So how can a laboratory result be correct technical, and you're telling me that it's wrong? So is that it can actually happen. So results can actually be technically correct, like Mrs. Usinachi said, is what you put into the analyzer that the analyzer gives you out. So the analyzer analyzes whatever it gives into it. It's just like garbage in, garbage out. For those that use automated analyzers, okay. The same thing if you're doing your manual too. If you make some pre-analytical mistakes, the results will come out based on what you've actually put into that process, okay. So results can actually be technically correct, but still be wrong. It can also be clinically wrong when it's even technically correct. So thank you very much for everybody for that. Precious, please, next slide.
Okay, sorry, before going to the next slide, I dropped my answer in the chat box. So you can
Okay,
also go
yeah,
back.
Precious, please, can you help us with checking at the chat box too, because you can always call us back.
Yes. She said, Joy said it is possible for a test to be technically correct and still be wrong based on wrong data capturing, having a wrong blood for test
Without
running.
data.
A
Exactly.
wrong data for test running, yes.
Exactly. So that's another aspect of it, right? So this is something we will see that happens more often than we like to admit. So these mistakes, these errors always happens often in the laboratory. So as we go ahead with this session, you begin to understand all of this, and that is exactly where good laboratory practice come into place, right? That's where good laboratory practice comes into place, and that's what we want to target today, and also our subsequent trainings as we go ahead in the ISN Biomedical Training School. So today, what do we aim to achieve today? So we want to make sure we understand the core principles of good laboratory practice. We want to also make sure that we recognize how good laboratory practice supports quality and competence in our laboratories. So how, when we put all of this into play, when we carry out good laboratory practice in our facilities, how will this support the quality and competence of our laboratories? Okay, so we want to make sure we recognize that, and we want to ensure that after this training, we understand the importance of good laboratory practice in laboratory testing phases. So there are different phases of laboratory testing, right? So we have we have the analytical, pre-analytical, we have the analytical phase, and we have the post-analytical phase. So we want to make sure that by the end of this training, we should be able to understand the importance of good laboratory practice in each of these phases, okay? And also, by the end of this training, by the end of this webinar, we want to make sure that you gain an overview, like an introduction to the ISO 15189-2022 requirements. So we'll be introducing the ISO 15189-2022 requirements as we go ahead with this training. Also, at the end of this training, we want to finally make sure that you understand, you identify practices that can improve your accuracy in your laboratories. It can improve your reliability and also improve your patient safety, okay? So when good laboratory practice is put into place and when we're following the right procedures and right requirements, we'll make sure at the end of the day, it is going to ensure that our patient gets the right result and they are also safe. So these are what we want to quickly achieve in the next few minutes that will be here. Next slide, please. All right. So we'll dive quickly into it. So what is good laboratory practice? So when people hear good laboratory practice, the first thing that usually comes to our mind are SOPs, documentations, maybe quality charts, quality control charts, sometimes even inspection. So when people hear quality laboratory practice, these are the things that hit them first. They will think, oh, good laboratory practice is just about standard operating procedures, right? Good laboratory practice is just about documentation. Make sure you're documenting properly. Good laboratory practice is all about your quality control charts, and sometimes even inspection and audit. That's the thing that comes to the mind of everyone when you hear about good laboratory practice. But I want to let you know today that good laboratory practice is much deeper than that. Good laboratory practice is much deeper than that. At its core, good laboratory practice is about controlling variabilities. It's about controlling variabilities. So every laboratory result is influenced by multiple variables, right? Some of the variables that can actually influence our results in all of our labs include biological variables. Biological variables like the patient's condition, the medication that the patient have had prior to the testing, hydration status of the patient. All of these are biological variables, right? We also have environmental factors, environmental variables that can actually affect result, that can actually influence our result. Environmental factors like the temperature. So if the temperature in your laboratory is not accurate enough, maybe your analyzer might not be working accurately. Also humidity, to when there is the humid condition in your laboratory is not good, can actually affect, and even power stability. Okay, so there are a lot of automated analyzers. When your power is not stable, it can actually affect how those analyzers work, right? So those are environmental factors and variables that actually affect our laboratory results. You have procedural variability. That is the procedure you use in carrying out your, how the sample is collected, how the sample is handled, how the sample is processed. All of these are procedural variabilities, right? So what good laboratory does is, good laboratories tries to create a system that minimizes the impacts of all of these variables, so that whatever report you have is not just a number, but a reliable reflection of your patient's true states. Okay, so what good laboratory does is to make sure all of these variables, the biological variables, the environmental variables, the procedural variables, the impact of these variables, you want to minimize to the barest minimum, whereby whatever results you're getting at will be the true state of your patient. So let me make this quick. There was a case in a laboratory where creatinine result was generated, and from all analytical check, everything looked perfect. So the results came out perfect, everything looked perfect. They ran QC for the day. QC passed. They did their calibration passed. They gave out the creatinine results, and everything looked perfect. The quality control was within range. The calibration was valid. The analyzer had no flag. No flag came out during the analysis. So the result was released confidently. Just imagine how confident you'll be to release that kind of result. But however, when this result got to the clinician, when the result got to the doctor looked at the result and said, this does not match the patient's clinical picture. Just imagine that statement alone is something that every laboratory professional should take seriously. So when you send out the result, you confidently send out the result, and your clinician is telling you that this result you just sent out does not match the patient's states. What do you think? So upon investigation, it was now discovered that the blood sample had been drawn from a line that was actively receiving intravenous fluids. So while what happened was that the person that actually went to collect that sample was actually an IT student in the laboratory, and the IT student had not been properly trained, and when she went to collect the blood sample, she mistakenly collected the blood sample from a blood that was actually receiving intravenous fluids. So what happened? The sample was diluted. Now think about this carefully. The analyzer did its job perfectly, right? The numbers generated were also correct, right? And based on the sample received, the numbers were correct, but the sample itself did not represent the patient's state at that time. So the result was analytically correct but clinically misleading. So this is part of what we actually talked about then. So, and this is the difference between just doing tests and practicing good laboratory practice. So we find out that a lot of facilities, they are just running tests, but they don't practice good laboratory practice. And this is why this webinar is here, right? So we want to make sure so why does good laboratory practice matter in medical laboratory? In medical laboratory. So it helps to prevent avoidable patient harm. Okay. So when this is done, when good laboratory practice is put in place, there will be minimal harm to the patient, right? It also helps to strengthen clinical decision making. So at the end of the day, whatever results we're giving out to our clinicians will help them make good decisions for the patient, right? Either good or bad decision. So whatever result you're sending out would inform your clinicians, will inform your doctors the kind of decision they will make. So you're invariably part of the decision-making process for the patient, okay? Because whatever result, if you give a wrong result, the clinicians will make wrong decisions. If you give a right result, the clinicians will make right decisions, okay? So it strengthens clinical decision-making. So when good laboratory practice is put in place, to strengthen clinical decision making. Okay. Another reason why this matters is that it reduces repeat testing and operational waste. Okay. So when good laboratory practice is not put in place, you want to repeat some of the analysis you carry out, right? So when this is put in place, it will reduce rerun, okay, for most of these testings. It will reduce rerun and also at the end of the day, reduce operational waste and reduce your cost of operations for your facility, okay? So good laboratory practice is quite important, okay? It also ensures results are defensible and trustworthy. So it's very important when you send out a result, you can confidently stand behind your result. You can confidently say, yes, I produced this result and I know that this result is accurate. Okay, so it ensures your results are defensible and trustworthy. You can defend your results when you put good laboratory practice into place. Okay, it will also enhance this workflow efficiency. When you put good laboratory practice into play, all of the requirements are considered. It will enhance your workflow efficiency. There will not be repeat testing. Your turnaround time will reduce and everything, your workflow will go smoothly and efficient. So it also helped that also. Good laboratory practice also improves staff accountability and professional discipline. It improves staff accountability and professional discipline. So when you put good laboratory practice into place, your med lab scientists can actually beat their chest and say, yes, I'm a professional and I'm disciplined because I've put up all of this, every requirement that needs to be put in place before any results is being sent out, okay? Then your staff will also be accountable when good laboratory practice is put in place in your facility. It will also build resilient and reliable laboratory system. It will build resilient and reliable laboratory system. At the end of the day, when your clients, your patients, right, are your clients, so when they find out that whatever results that you're producing from your lab is reliable, it will build trust in your patient, okay? So you can actually get referrals and also get to do great things with your facilities. That's because good laboratory practice is put in place. It also drives continuous improvement and quality growth. So good laboratory practice will drive continuous improvement. So as laboratory personnel, we want to make sure that we are competent. We are also improving. Even as we're working, we're also improving. So when good laboratory practice is put in place, it will ensure competence for your personnel and also their professional growth, okay? Yeah, so good laboratory practice in different phases. Like I mentioned earlier, so we have different analytical phases, right? We have the pre-analytical phase, we have the analytical phase, and we also have the post-analytical phase. So one of the biggest misconceptions in laboratory practice is that most errors occur during testing. So people think most error is during the testing phase, during the analytical phase that it happens. In reality, that's far from the truth, okay? The majority of laboratory errors occur before the sample even reaches the analyzer. Please confirm you can still hear me.
Yes.
Can you still hear me? Yeah, great. Yeah, so the majority of errors occur before the sample even reaches the analyzer. So we classify errors into three phases, like I mentioned, the pre-analytical phase. So there are errors that can actually be classified under the pre-analytical phase. There are errors that can be classified under the analytical phase, and there are errors that can come under the post-analytical phase. This means that if your focus is only on running controls and calibration, you are only addressing a small part of the problem. So if your focus in your laboratory is just about running calibration, so just about running control, that means for your facility, you're just addressing a small part of the problem. Let me give us an example. A patient potassium result comes out extremely high, something like let's say 6.5 or 7.0 millimole per liter. Now, if you're not practicing good laboratory practice, the tendency is to immediately report that result, especially if the analyzer did not flag any error. So people want to make sure that, oh, since my analyzer is not flagging error, that means the result is okay. But a more experienced and good laboratory practice driven professional will pause and ask questions. So when you get a result like that, 7.0 for potassium, someone that is not conscious about good laboratory practice, as long as the analyzer does not flag any error, they want to release the result. But a good laboratory practice professional will stop at that point and ask questions. Questions like, was the sample hemolyzed when it came into the lab? Was there prolonged tourniquet application? Was the sample shaking vigorously, maybe while moving from the phlebotomy unit to the test in the laboratory? Was there any vigorous mixing on the sample? Was there delay before centrifugation? All of this can actually impact the result, that kind of result, because what you're seeing might not be the patient's potassium level. It might be potassium released from the red blood cell due to hemolysis, okay? So a good laboratory practice driven person will always, when you see results like that, the good laboratory practice personnel will always calm down to ask questions. And that single moment of questioning can be the difference between saving a patient from unnecessary treatment and causing harm to the patient. So let's look at the pre-analytical phase. What's the pre-analytical phase? So this pre-analytical phase is where the real battle for quality is actually fought. In the pre-analytical phase, this is where the real battle for quality is actually fought. The pre-analytical phase begins from the moment a test is requested and continues through patient preparation, sample collection, labeling, transportation, and storage. So the pre-analytical phase is the critical first stage in laboratory testing, beginning when a physician orders a test, that's when the test was requested, and ends when analysis begins. So from when your clinician requests for the test, pre-analytical stage have started already, until when the test is ready to be analyzed on the analyzer. So it encompasses patient's preparation, specimen collection, labeling of samples, transport to the laboratory or to wherever the analysis will be carried out, and also the initial processing that before sample reaches the analyzer, okay? And every single one of these steps carries risk. Every single one of these steps carries risks, okay? So the specimen collection, patient preparation, there are risks in patient preparation, labeling of sample carries its own risk, transport of the sample also carries its own risk, and also the initial. Let's take patient preparation for example. If a lipid profile is done on a patient who have not fasted appropriately, the triglyceride level will be elevated, right? Please, let's reply. You reply me so I will know you're hearing me, please. So if a patient comes and you collect a sample from a patient that have not fasted appropriately within the period that they are supposed to fast. When you run the analysis, triglyceride level will be elevated, right? Let me know that I'm still.
Yeah.
Yes, exactly. Yeah.
Yes, sir.
Thank you very much. So now consider some. So now imagine the results being interpreted without that context. So when that kind of result is being interpreted without putting this in place, that this sample was collected when patients have not fasted. So that's patient preparation. So that's the risk involved in patient preparation. There are other risks, but I just want to point this out to us. That's during patient preparation. So during patient, if a lipid profile is done in a patient who have not fasted appropriately, triglyceride will increase. We could end up labeling. So for imagine results being interpreted without the context, you could end up labeling the patients as having dyslipidemia when in fact the issue was simply improper preparation. So that's the risk involved in improper preparation. So let's also look at sample collection. An example is sample collection. So hemolysis is one of the most common issues, and it often results from technique using a needle that is not too small, applying excessive force during collection, or even improper handling of sample after collection. So when red blood cell ruptures, intracellular contents like the potassium and lactate dehydrogenase are released into the plasma, right? So now your results are altered, not because the patient had a problem, not because the sample was, but because the sample was compromised, right? So a mislabeled sample is not just an error, it's a potential clinical disaster. So in labeling, there's also a risk in labeling also, okay? So common good laboratory mistakes that I can encounter during the pre-analytical phase: patient and sample ID error, patient misidentification when you don't identify the patient properly, unlabeled sample, or mislabeling causing specimen to patient mismatches. So take a look at the screen. You see two different kinds of samples. The first picture there. So you see two different kinds of samples. So one of the sample is plotted and the other. So from this sample now, which of them do you think will be good for analysis? So this is an EDTA container, right? So this should be for, let's say this is for hematology testing. So this kind of container, which do you think would be appropriate for testing? Please you can answer. You can unmute and answer.
The one that is not plotted.
Yeah, great. So this is another error that you can actually look out for. So collection error is also another one when a wrong tube is being used. So for maybe for chemistry analysis, you mistakenly put them into a wrong container, or maybe when insufficient volumes are collected for a sample. Hemolysis, like I mentioned before, can also be another issue, another collection issue. Clotting. So like this one now, you see that this one is clotted already, so it cannot be used for hematology testing. Improper. Someone saying something. Okay, so let's just go ahead. So improper techniques compromising sample integrity. So if you look at this other picture, the one at below, you see that how this labeling was done. So this is a facility that is using an LIS system. So you can see that this is a barcoded sample. So you look at the first picture, you see that this first picture was properly labeled. Then look at this other picture. You see how the labeling is done, how the barcode is placed on the sample tube. So this is another error that can actually happen during the pre-analytical phase. Transport and storage errors. So delay in delivery. Maybe a sample was collected and want to be moved to maybe a reference facility. So you collected your sample from maybe a smaller laboratory and you want to transport it to a reference laboratory. So if there is delay in delivering this sample, it can actually be a risk during the pre-analytical phase. Incorrect temperature maintenance. So when samples or specimens are being transported, most specimens should be transported within the right temperature, right? But when these temperatures are not properly maintained, it can actually cause an issue, okay? So we'll quickly move to the next phase, the next phase, which is the analytical phase. So I always say this phase is where precision can mislead you. The analytical phase is where precision can mislead you. And this is the part where most people are usually very comfortable. It has gotten to the analytical phase. It's just for the analyzer to carry out the analysis. That is on. So people usually feel that this is the comfortable phase. This is where we deal with instruments, where we deal with reagents, where we deal with calibration, and also quality control. All of this is where I want to introduce a very important concept, the difference between precision and accuracy. So before we look at this, so the analytical phase is also called the examination phase, right? It's the second stage of the laboratory testing cycle. It begins after a specimen has been received and logged into the laboratory. And it includes all activities involved in performing the actual laboratory testing, performing laboratory assay and measurements. This is in the analytical phase. Following validated testing procedures is carried out during the analytical phase. Using calibration and well-maintained instruments, applying your internal quality control is also during the analytical phase, and ensuring precision, accuracy, and reliability. So this is where I want to actually talk about precision and accuracy. So those are two very important aspects of this phase. So an analyzer can give you very consistent results. So when an analyzer produces very consistent results, you can say that your results, there is precision in that analysis, right? But if those results are consistently wrong, then you have a problem with accuracy. And one of the biggest risks here is ignoring quality control signals. So this is where you need to look at your quality control signals. There are situations where QC results are slightly out of range, and due to pressure or workload, someone decides to manage it or proceed anyway. So sometimes you run your quality control and it will fail, and you look at it, the result is this result is close to the range, and because you have a lot of samples to analyze for that day, let me just overlook and let me continue. This is a great risk. That decision might seem small in the moment, but it introduces systemic error in every patient result that follows. Okay, so when you overlook that QC and say it's just a little bit above the range, let me just continue like that for the day. You've introduced systemic error into that system, and it will affect subsequent results that have been produced from that analyzer. Another important issue is reagent integrity. A reagent might still be within its expiry date, but if it has been exposed to improper temperature or storage condition, its performance can degrade. And this is where experience becomes critical. You see, so we've had cases where we visited facilities, and those of them that use automated analyzers, you look at the analyzer and you see that for expiry date, there are two kinds of expiries. Okay, there are onboard expiry and there are packet expiry. So you see that this facility, they've loaded the analyzer into the analyzer. When you load the analyzer, you load your reagent into your analyzer, the onboard stability will start counting. From that day, you load your reagents. The onboard stability will start counting from there. And for different reagents, there are different onboard stability. So there are reagents that can last onboard for up to like just a month, some for 2 months, some for 3 months. So you need to always look at your IFUs, that's your instruction for use manual, for all of your reagents to know their onboard stability. So for some facilities, you see that their onboard stability has elapsed, but they are still making use of that reagent. Oh, we're trying to cut costs. We don't want to waste our reagents. But that is going to pose a great risk for your facility. because good laboratory practice is not just about checking expiry dates, it's about understanding reagent behavior. So you want to make sure that your reagents are behaving appropriately the way they are supposed to behave. You may even see situations where some assay pass quality control while others fail, and that often confuses people. So they will say, I ran quality control on all of my analysis for the day, all of my parameters for the day. Why is it that some are passing and others are failing? So this is based on its parameter specific. So different parameter behaves differently. Okay. So there are some parameters that you run quality control on, and they will pass for today. Tomorrow you might use that same quality control material and run on that same parameter and it will fail. That's because there is a way that parameter behaves. So it's very important that we take note of all of this. Go through our IFUs and make sure we understand the behaviors of all of these reagents. So some common errors that we can actually see during the analytical phase is one, the human errors, pipetting mistakes, method deviation. So you see a situation where someone will mistakenly, I'm in a hurry, let me quickly do this, especially for those that use that still run on manual methods, and you pipette mistakenly. So that's part of human error that can actually affect your analytical phase. Mechanical and instrument error is another one. So calibration issues. So you must always make sure that your analyzer is properly calibrated and is not malfunctioning. Okay, your analyzer is properly calibrated and is not malfunctioning. Another issue you can actually see is method issue. Wrong method. So you're using a wrong method for different analysis. It can actually affect your analytical phase. Okay, unvalidated procedure. So for good laboratory practice to be in place, you must always validate all procedures you use in your facility. Make sure they are properly validated. When you use an unvalidated procedure, it can also pose a risk. Okay, QC errors, ignoring QC failures, poor
Hello, sir. Are you still with us?
We have lost him. All.
Just hold on. You'll join back shortly.
So this one can be called
Please hold. Please hold on.
Can you guys hear me? Can you hear me, please?
We lost you before, but we can hear you now.
We can hear you
Sorry.
after the cognitive error.
Oh, sorry about that. Sorry about that. Okay, so when quality control, right? Quality control errors. So ignoring your QC failures can also be an issue. Reagent issues are also expired or improperly stored reagents. So you always make sure that your reagents are stored properly and they are not expired. Both onboard and pack expiry is not compromised while using those reagents. Environmental errors can also be another mistake. Temperature, humidity fluctuations in your facility. So you make sure that for your facilities, they are properly, the temperature is within range recommended for most of your validated testing procedures, and also and also the humidity is within range also, and there are no contamination. Okay, data and calculation error. So for manual computational mistakes, so maybe when you're doing calculation, especially for those that calculate manually, okay, so you make sure that whatever calculation you're making, whatever calculation you're carrying out is actually the right calculations. Okay, so these are inherent errors that can actually be seen in the analytical phase of your testing. Okay, next slide. So this is where I will stop, and Nkem will take over. So let's quickly look at the post-examination phase. So the post-examination phase is the final stage of the laboratory testing cycle, beginning once analysis is completed and ending when results are delivered, interpreted, and acted upon. So this phase is not complete until a decision has been taken on that patient. So in this phase, you can actually see cases where you will need to rerun a particular parameter, you need to rerun a particular test. This is still in the post-analytical phase. So this post-analytical phase is not complete until the decision has been taken concerning that result. It includes result verification, authorization, reporting, communication to clinicians, storage of results, and documentation of any follow-up action. Maybe there's any follow-up action, you need to repeat a testing, and ensuring that the laboratory output is both meaningful and clinically useful. So at the end of the day, we want to make sure that whatever result you're producing is clinically correct, is clinically useful, not just technically correct, not just that your analyzer has given you a result and there are no flags and it's technically correct. We want to make sure that whatever results that you produce is clinically useful and actually shows the state of the patient at that time. So why does this matter? Error in this post-examination phase accounts for 18.5 to 47% of all laboratory errors, such as incorrect reporting, delay, transcription mistakes, or poor communication, would directly affect clinical decision and patient outcome. Even accurate test results can lead to wrong diagnosis if they are not communicated clearly, promptly, and correctly. So you might have you might have carried out your analysis properly, you might have gotten good results, but when these results are not properly communicated to the clinician, communicated to the doctor, they are not communicated promptly. Maybe the results came in late, or maybe they are not communicated correctly. This can actually affect your results. So it's not just about um, producing the right results. It's about communicating the right results to the right stakeholders, to the right persons that are in charge of patient management. Okay, so your communication should be clear enough for those stakeholders, those that are involved, to understand properly, even without hearing from you. Okay, your results should come promptly. That's where turnaround time comes in place. And I bet you when you put good laboratory practice into place, it will definitely reduce your turnaround time. Okay, so those results must come promptly and they must also be correct. Okay. Yeah, so I'm seeing that someone have a question. Please, you can just put it down. At the end of the session, we'll take all the questions, right? Yeah, so I will end here and Nkem will continue from here. Thank you very much.
All right. Good morning, everyone. I'll be using Precious's computer to be giving this lecture. He has talked about the pre-analytical, post-analytical, and the analytical part where you're doing your QCs, your calibrations, and running controls. And my part of the webinar is to talk about the ISO 15189-2022 requirement. ISO, the International Standard Organization, or Organization for Standardization, came up with the ISO 15189. Over the years, it has evolved. The last one before the review in 2022 was the ISO 15189-2012 version, which was talking about audit readiness. Can you hear me? Is somebody saying something?
Yes, we can hear you.
Okay. Talking about competence, preparing your laboratory to perform properly. There's a whole back. Mr. Paul, could you please mute your mic? Mr. Paulita. Thank you so much. So as I was saying, the International Organization for Standardization has evolved this requirement for testing laboratories. So it's standard procedures for labs that perform tests that are used by doctors. As opposed to getting your lab ready for audit and being compliant, they have moved away from that to being patient-centered, risk averse, and risk preventing, so that results produced by laboratories do not cause harm to patients. All laboratories globally are governed by this standard. And what it means to the lab is you'll be operating fully controlled, quality-driven system where processes from sample collection in the pre-analytical to the post-analytical part of the laboratory is standardized, documented, and continuously monitored. It means that the lab must ensure competent staff, properly maintained equipment, reliable reagents, and completely traceability of all its activities. It also requires that the lab is actively identifying and managing risks, preventing error before they even happen to the patient, and continuously improving their process. In simple terms, just means that the lab is not just doing tests, but delivering accurate results, reliable and patient-focused results within a structured quality management system. The scientist at every point in time is aiming to deliver accurate results. He's properly trained on the procedure. Even if it is a manual pipetting procedure, the scientist has a documentation of having been trained on how to pipette accurately, avoid error due to parallax if it is because the lab is using an automated system. The people that supplied the system continuously train them, because most of our scientists are looking for the best paying opportunities and they move from lab to lab. Or we are graduating fresh people. A lot of other people are retiring. To replace the people that have retired, we have new graduates that are coming in, and there are systems in place to ensure that these staff are competent. It requires that we focus on our patient. It is not that we are looking at our tests that we are running. At the end of every test, there is a patient's life attached to it. It also emphasizes, you remember when Rufus was talking about the errors in the lab? It can be anywhere, and majority of which happen even before the samples come into the lab. The labs require to take mitigating steps to ensure that those risks do not happen. The most common of it is in a very busy lab. You have patients that have wandered through the hospital and their relatives come to the lab and they are asked, next patient, they are sitting patiently waiting for their time. They come in, the sample is being drawn for the patient relative because they heard the patient's name and they thought it's their turn. You are drawing the sample. As you draw the sample, what next are you doing? You are processing the test. You did not have a protocol for the pre-analytical technician or phlebotomist or scientist collecting the sample to identify a patient. There is a requirement to prevent that a normal person's result is not transferred to somebody who is sick and the person is discharged. It emphasizes that all our results must be reliable. And at every point in time, we do the right thing in a structured, documented environment. So the key principles of good laboratory practice can be found to be mirrored in the ISO requirement, where it says ethics, confidentiality, and impartiality. In recent times, because of the harsh economic situations, you know that when most scientists take a vow, we said we shall do no harm and we shall maintain the ethics of the profession, confidentiality of the patient, and impartiality in the sense that we cannot be swayed to change our results anyway. You can find out in the clause 4 of the ISO 15189/2022, the general requirement of what is needed to be happening in the lab. Then good governance and clear responsibility. You know how you have the responsibilities of the manager separate from the responsibility of the people working on the bench, separate from quality manager who, like, if I should ask, what's the responsibility, whose responsibility is quality? Is it the quality officer or manager or the people taking out the process? Can somebody answer, please? Hello? For laboratory quality, who is in charge? Is it the quality officer or the people conducting the tests? Nobody is on.
I believe it's everybody.
Everybody. Do we agree? So,
Yes, I do. Everybody should be involved.
so the person that said everybody and the people that said is the quality officer, why?
Because I feel quality needs to be executed, so it's not just about knowing what to do.
Okay. The person that said quality officer, please, nobody is wrong, go. Hello? There's no grade for saying the answer now.
Hello.
Yes, hello, please go ahead, Paul.
Yes, I think it is mainly the people that are conducting the test that should be in charge of the quality quality of the procedure. So the quality control, the quality officer should be like kind of oversee what the people doing the conducting the test. Do you understand?
Yes, I do.
So that's how I say it.
Okay. So it is everybody's responsibility. Quality officer monitors, but that is just like if your quality officer, the quality officer may not even be a laboratory scientist. If you are a person working on the bench, you are the expert. You are the one in charge of the beginning to the end. You were trained to control the environment. So it is your responsibility to document what you do, develop a process, writing SOP for what you do. Because you are the one that is competent to be able, have the license to practice. What the quality officer does is to ensure that what you do is in the way you said you are doing it and it is yielding the accurate result that is desired. So the ISO 15189 requires every laboratory to have a management system that predefines these requirements per person. You're not sharing the screen. Please, can you see the screen? I'm somewhat confused.
Yes, you can see it.
Okay. So it requires this good governance, even for good laboratory practice. It needs you to have documented job descriptions defining where everybody's role begins and at the end, who takes it up from the end. Because it's like a relay race. You cannot collect sample, document it, spin it, run it, enter it, and still interpret it. The doctor will request an investigation. You need to gather information, clinical picture, age, sex, because some of these have impact on the quality of results that you produce. Remember the 8 millimoles per liter test that you're getting for a diabetic patient who has been managed over the years and it has become the person's normal result. Do you have documentation on whose responsibility it is to collect the results, run the results? After you run the results, if the results are critical, do you communicate it to the doctor? Are there clear guiding job descriptions for everybody in the laboratory? It is a requirement so that everybody knows what they are doing per time and take responsibility and accountable for it. So this ISO, it wants scientists to take responsibility and ownership of all results that are produced, because at the end of the day, when push comes to shove, you are the one that is responsible for reliable test results while working in a quality system. Quality is ambiguous. Quality is how you deliver things. You know, Coke in Sheraton and Coke at one Meshai's place or Aboki Corner, they are not the same thing and you don't pay the same price. But he has a way of refrigerating his Coke. But the environment and how it is given in a chilled glass with probably a slice of cucumber, and when you have it just by the roadside in one dirty corner, it's not the same thing. What this does for us is to tell us that scientists will check the equipment, reagents, and ensure that they are functioning in the right way so that at the end of the day, results are produced in the right manner. And they have to be traceable. Traceability in the sense that, you know how you have the HIV package inserts? Your process is to, if you are using that strip, everybody must follow the protocol. If it says allowed to stand for 15 minutes, anything after 15 minutes, do not accept. If it has stayed on the bench for 30 minutes, it's not that you will now place it, collect a pasture pipette. It tells you to drop 3 drops. You just extrude it, and leave it on the bench. Before 5 minutes, you say, oh, it's negative. You go and enter the result. There is a maximum reaction time required for tests. And for the ISO 15189, it focuses mainly on the processes to achieve your patient safety. Clause 8 says management system, traceability, documentation. If you produce a test result and it is not written down anywhere, you cannot trace it anywhere. Is that result good? Can the doctor use a result that is in the air? It has to be documented. So also, all procedures, all processes in the lab is a requirement for both good laboratory practice and the ISO 15189 2022 version. So, principle 1, we have to be patient-centered. The services we do, if we do not have patients or people that are sick, we will not probably be in the business of laboratory testing. Patient safety should be priority, because imagine if it is a lab, you know, good news spreads like wildfire. Anytime you come to a lab and they give you accurate results and the doctor uses that result, because these results are used by doctors, not by the patient. The doctors interpret it and now determine the line of action they are going to take, what medication they are going to give to the patient, who gets what dose. Imagine a microbiology where you just give a result and you just say, yes, all the antibiotics are sensitive. You did not do proper quality control to find out what organism. You just said missed growth. All the antibiotics are sensitive. You know, the doctor will come back to you and say, I don't understand what you did. You need to tell me it's 1, 2, 3 organism, whether it is Staph aureus, whether it is E. coli, whether it is Pseudomonas, and the respective antibiotics that you have tested, the ones that are resistant, the ones that are sensitive. If you give them the antibiotics without giving them the name of the organism, they will look at your lab and say, it's as if these people don't know what they're doing. By the time they send the person, the first time it happens, the second time they'll say, let me just try them again, and you give the same thing, they will write you off. And you know doctors talk. Results will not give accurate results. Maybe over time, you have been giving them consistent results. It's a new place, you have new instruments, you've not been checking your analyzers. You don't run quality control. One day there was a spike in electricity and you just gave out a full block count result that is high for WBC. And they look at the person, he's not having any sort of clinical indication stating that. And they now send him out to another place to have a result. Do you think the people will come back to you? Because at the end of the day, if they had followed that your line of suggestion and probably started the person on chemotherapy because it's suggesting that the person has cancer, without looking at other consideration, do you think they will come to you? Or when a result is listed, say, Obasanjo came to my lab today, and you publish the results. Even other people will not want to come to your lab because your lab is a risk. You can have my information anywhere on the social media. That is why we need to be, number one, empathetic. Focus on our patients, because without our patients, we cannot be in business. We need to operate in an ethical manner, unbiased. You treat a rich man the same way you would treat a poor man, because the rich man may come just once in a while because he cannot travel abroad. But that poor person that you're looking down on, anytime he's sick, he will come to you. You need to be neutral and always treat the person as a king, because 1,005 in 100 places is better than one person consistently coming over a period of time than 1 million that will come only once and you will never see again because your standard is not up to par. It's just by chance they are coming. Imagine if you have a consistent laboratory that is focused on patients. Even those small people will still bring their bingoga. Come, I have a place that they are giving me accurate result. Have you tried it? Come. Even though, don't mind, I'm looking forward to you, but these people are giving me answers. Have you seen me sick? That way, you will gather clientele. Reliable and clinically relevant results every time. When we implement this good laboratory practice, COM ISO 15189 requirement, effective communication with users. If your result is not going to be available at a certain time, do not keep quiet and try to troubleshoot. Communicate first. Do you have a turnaround time for your results? Those results, are they going to be available at the time? Scientists must communicate with the phlebotomist because they are the front line. Or if you have a front desk, communicate with them that this is what is happening. It's a requirement that at every point in time, imagine if a troponin I result was delayed. You could not meet up with your turnaround time because all of a sudden, sometimes you cannot control these events when they happen, just like driving on third mainland and your car stops in the middle of the bridge. You have to have a documented protocol to, first of all, think of your clients. They need this result. They cannot just come to you because they like coming to you. You're not selling ice cream. You're not selling rice and beans. They need to eat. They can as well go somewhere else. They must not come to you. But because they need the result to sort out an ailment, if for any reason result is going to be delayed, even if it is a wrong result that was issued, it behooves on you because you have the patient at heart to communicate to the client. If possible, reach out to the doctor, because if you do not communicate the result, it's as good as you did not do anything, because you did not meet the final requirement, which is to be used for diagnosis and profile prognosis for the client and the treatment plan. This scientist is a very competent scientist. He can run 200 samples in 2 hours. Ogdogu is a very good guy. But ISO 15189 requires that to achieve this kind of machine in the lab, you need to train them. You need to have a training plan. Do we document how, when new people come in, we onboard them into the system? It is a requirement of the ISO 15189 2022 that it is documented so that it is consistent. Do you have a training plan? Even for retraining the old scientists, sometimes, we tend to believe we know it. Chinese whispers, where you tell somebody something, several persons down the line, you find out that the result, they've added salt, they've added pepper. Imagine somebody went to a scene where a husband and wife is fighting. They don't know what happened, but they know how the blows were thrown. When they go out, the story they will paint is a different story. We imagine Nollywood in action. You say, Omo, that story enter. Imagine if you have an SOP and you don't have a training plan to onboard your new staff. It is watered down. If it is not documented, if you do not have a plan, okay, if this person comes in, the person first of all has to go through how registration is done, interact with the client, go to your phlebotomy, find out the phlebotomy requirement, go to the lab. This is the process that happens in the lab. When in the lab, do you just throw them into the bench because they have 15 years experience working on the bench? Your process may be different. They may have training on automation, but are all the instruments the same? Do you have an orientation timeline of which the person needs to observe and internalize your standard operating procedures? Every lab has a different procedure. And even if you have 50 years of experience, you need to calm down, understand each person's procedure before you now start bringing in your wealth of experience. If the lab does not have a training plan, the person will just believe that they can bring whatever they've learned, probably an EBA, and use it on a C111. So ISO 15189 requires that each laboratory must have a clearly defined onboarding plan for new people. Even for training old staff, there should be a true retraining program. That is all that leads to having a competent scientist, a competent phlebotomist, even your cleaner, and the person at the door. If you have a gate keeper who opens and closes your door, you need to also train them, because when infection wants to start, it does not start with the people that are competent in the lab or the phlebotomist. It starts from the door, because they are the first people that interact with those patients. So there should be some kind of onboarding for all cadres of staff that come into the laboratory. Be it a cleaner who you think is inconsequential, and you will send that person to buy food. By the time they do not wash their hands, they will use gloves, touch the door, touch your bottle, and bring it for you. They are running very good errands. Because the person does not know the consequences of their actions, you will not know when the thing will get to you. So it is imperative for every laboratory, as per requirement, to have an onboarding program for all cadres of staff, and it must be documented. And you need to have regular assessment, be it by somebody or lab manager or the quality officer coming to check. You read the SOP. You now come and see, are they following through on what they are doing? This thing that they have said they are doing, are there any risks inherent? Maybe you brought in a new instrument, and the new instrument now tells you that they require only lithium heparin as opposed to the serum you are used to. Because difference in sample per manufacturer, because they have done statistical analysis on their instruments and reagent requirements, it may require that you change your collection procedure. Even for hormonal assay, for labs that perform hormones, you need to have a training, especially for onboarding new instrument or new method, or you buy a new kit. You need to be consistently vigilant, because lithium heparin and citrates, some instruments use lithium heparin for D-dimer and some use only citrates. If you interchange, it may affect the quality of results that are produced. Hence, the need to have regular competency assessment with respect to, are they doing this thing that we say we do, or have anything changed that we need to change, and retrain people that this is what is happening now. Then authorization for specific activities. For instance, a lab technician runs a test and gets a result of 7 for potassium. Is it that technician that calls out the result? For people that have call-out centers, are those people equipped with the requisite knowledge, or can they transfer information when poked or probed further? Do you have that documented in your process of training? They said, Rufus said, we should have something to check our pre-analytical error. It shouldn't be, they said, it should be a requirement, because it is a requirement, not because it is said. And at the end of the day, it should be properly communicated. The downside of why this is being done, because if you know the why, you will run with it, because most competent people, when they come to work, their aim is not to go and kill somebody. And you know, like I'm a Christian, it is said that my people suffer for lack of knowledge. So we need to arm them with the requisite knowledge for the practice. And continuous professional development is not only attending seminars, webinars. Each one can teach one. A senior scientist can teach a younger scientist. A cleaner can come up with a protocol, because he is the one that is in charge of maintaining the general cleanliness of the lab, and come and train the scientists that, based on my work, I have observed that some sharp objects are sticking out and can cause harm. Can we do this in this way so that I will not have infection that will be adverse to me? Nobody is too big or too small. You need to organize continuous webinars. You don't need to have it only external. Thank God for AI now. We need to use it in a positive way. You can do research. Cambridge is at your fingertip. You can do research within your lab, and one person can come and organize a webinar. You must not be paid. We need to be continuously upgrading. Science and laboratory practice is dynamic, and we need to be abreast of what is happening. And this should be conducted at a predefined time by the laboratory, and it must happen. Principle 3, we've mentioned standard operating procedure. Who writes them? It should be the people working on the bench. If you have an instrument, you should have a standard operating procedure of how to operate that instrument. Everybody must be aware, especially the stakeholder. You can take the most senior and the most junior person, form them as a team. They write it. Once they write it, they send it to the lab manager for approval. After it has been approved, you test it for a period of time. Then you issue it out and do a training for everybody. This is requirement, and you should continuously monitor that standard operating procedure to establish its efficacy. It is required annually to review your SOPs, whether they are still valid. It is not, yes, I have written SOP, and that is the end. Something may change and you need to update it. Verification method. Do we have a protocol for verifying our instruments, or is it just plug and play? You know how you will buy a washing machine or a TV and they will say there's a warranty period. It is in the using of the instrument. You will find out whether there is a factory error. That is why they issue those warranty. If you collect an instrument and you do not verify that it is fit for use, do you do a precision testing? Do you do a correlation testing? Are your instruments on EQA to validate the consistency of it? Do you even have a protocol for validating those instruments that come to you? How do you now detect factory error? It is a requirement that you have a method to validate your SOP, validate your lab standard operating procedures, that they are fit for use. Are they referenced on your own method? Did you develop that method? How did you validate it? There must be documentation of all these processes. Are the documents controlled? For instance, if your process is changed, do you have who is authorizing it? Do you have who reviews it? Do you have who approves it? Is it documented? What is the structure? Are we going to be using ×2 Roman? What is the format of the text? Is there a risk and mitigation step inside the SOP? What will be the structure? Do you have a template for your SOP? Do you have a template for your document? Do they have versions? Do they show where it is reviewed when there are changes? All the changes must be documented to show that you are even reviewing it. Even if there's no change, it will be written, no change done, so day. And it has to be dated to document that it is even being reviewed, because in quality management system, anything that is done and it is not documented or written, it means that you did not do it at all. That's number 3 principle. Staff adherence to the SOP. The SOP is in the lab. Who is the gatekeeper? The lab manager, is he monitoring that his people are doing the right thing? Are the team leads reviewing what the people are doing, pari passu the standard operating procedure for that particular thing? Who is checking? This is a requirement, and we need to come up to par with all the things that are happening. Why do you document? You know how you go to, I don't know how many of you have traveled far. You see in a place, I've traveled, Virgin Atlantic, you see that their air hostesses have the same lipstick if you monitor. Even for airpiece, you see that a particular set of people are wearing the same kind of pop socks. Their skirts are the same, their uniform are the same. Do you think it's because they want to wear those kind of things? It is specified somewhere. For Ethiopian Airlines, there's a specific way they pack their hair, and it is like that. I went to a hospital. On coming into the hospital, they have like 3 or 4 branches in Lagos. All of them smell the same way. Probably they have an SOP on the kind of scent they need to buy. Classical example that will sit home with us, Chicken Republic. If you go to Chicken Republic in Ibadan, go to Chicken Republic in VI, do you know their rice tastes the same way? Why do you think it's like that? It's because probably they have a recipe which stands for in the lab as a standard operating procedure that everybody must follow. They will tell you it's remaining 3 minutes for the chicken to be done. No, kindly wait. Do you think it's because they want to tell you 3 minutes? No, because they have a timer and there is a standard procedure for cooking their rice to achieve that particular thing. At home, we cannot achieve it because we don't have any recipe. But believe you me, if you have a recipe for cooking, your food will always taste the same way, which my husband is constantly telling me that I have to do, because every time I stew, Madam, your stew is not tasting the same way. Why? Can't you stick to one stew? I know a lot of us can relate to this. So what standard operating procedures does for us is not because it is what the requirement or principle demands us to do. It is so that our work is consistent, so that even if it is a new graduate or somebody that has practiced for 20 years. We are following the same process to achieve the result. Not that when somebody disappears, the normal way of doing things will go with the person. But as far as it's documented and somebody is checking to see that everybody does the same thing and is adhering to those protocols, it remains consistent and nothing will be missed and will continually get accurate results. Principle number 4, reliable equipment and resources. We've bought instruments. We don't want to come for ISN's maintenance plan. That you do not maintain your parts is just like your instrument. It's just like you are driving a car without changing the oil. Syringe will bend because of wear and tear. The manufacturers, in their wisdom, even for your testing kits, you need to monitor them. You need to calibrate you as low as your pipette. Pipette has yearly requirements for calibration. According to the CLSI guideline, you should at least calibrate your pipette once a year to ensure that it is pipetting the correct thing. You know how you have our doors in the house? During the dry season, you find out that any small breeze, it will be making sound, or if you jam one door, it will open another door. But during the rainy season, it doesn't happen. Why do you think that is so? It's because of moisture. When dry season or dry weather comes, especially for those homes that have had wood door, it shrinks and expands. So also our pipettes. If it fails calibration, yes, MLSCN now is calibrating pipettes, and they are calibrating even timer and temperature monitoring devices like our thermometer. They have to be calibrated to ensure that they are monitoring and dispensing at the right way. Imagine even our watch that we wear in our hands needs to be calibrated, but who cares when we have phone and every other thing that we can see? When the battery goes down, the timing is also going down. It will not function well. You know how your phone, when the battery is draining, the light is going down. So also our instrument, over time, the ability for them to produce accurate results are also going down. If we do not maintain them, there will be issues with our results. We need to calibrate them, including our timer, including our pipettes. We need to be having certificate for those because there is certificate issued at every point when instrument is calibrated. For instance, for those of us that have automated chemistry or hematology analyzers, when they are calibrated, your instrument prints out a result, which stands as a certificate that, yes, this has been calibrated. If it fails, your instrument will tell you fails because they have a 95% confidence limit of which the certified reference material, if it operates above it or below it, your calibration will fail. The acceptance testing before use. Like I said before, did you validate the instrument? When you got a new kit, did you test it to find out that it's working correctly? These are very, very important requirements. You can test it by running control, you can test it by running QC, but you need to test the precision before you even put it to use. Are they reproducing well? And it is not just done once. You need to engage in an external proficiency testing that tests the accuracy of your results. Are you subscribing to this? Because all these are to ensure that all the tools that you use are producing accurate results that will not cause harm to the patient. Proper reagent storage. We are running a lab and NEPA takes light. Your fridges are not on any kind of inverter. The cold chain, freeze and thaw of those reagents. And mind you, Nigeria is not a very cold country. We are hot. More often than not, we get 32, 38. And for cold reagents that are supposed to stay 2 to 8, they also have an adverse effect with respect to how the fridge functions. Do you know on days that it rains and the temperature is cold and humid, the fridge operates optimally and the room is cool. When it is hot, you find out that your cold water is not as cold as it's supposed to be. Even though doctors say we should not be drinking cold water, me I drink cold. On very hot days, the water in the fridge is not as cold as it is on cold days. I would tell us to look at it. So we need to monitor all these things and document them so that we will not be used. Anybody still hear me?
Yes, we can hear you.
So what was the last thing I said, please?
We can hear you now.
Okay. So what was the last thing I said, please?
Difference between cold water on a cold day, rainy day.
And the fridge, yes. Okay, so you're still following. With respect to storing reagents, I said sometime in 2024, we had to send back some reagents and demand that they change them because it was discovered that on EQA, some certain analytes were failing on the immunoassay system. If we did not have that EQA, that's how we probably have been sending out results that were wrong. We filed for them to replace those reagents because we could prove beyond reasonable doubt that those things were not properly working, and they traced it to their supplier in France. They had a failure on temperature at some point, and it compromised. You know, enzymes are affected by temperature and pressure. So the enzyme was denatured for the substrate for developing the testing in the testing procedure, and that invalidated the reagent, and it could not produce reproducible results. Imagine if we were just issuing out results and we did not have any EQA to check it. That's how it would have caused a lot of people to have issues, especially for troponin I. We need to have a method of monitoring the reagents and storing them. Temperature monitoring cannot be overlooked, and we need to have evidence that we are doing this. Some people have real-time monitoring devices. Some use the manual method of sheets on Excel. You can, if you say you don't want to use paper, you can document it, but ensure that somebody is looking at it, not just signing off the temperature. There are reasons why you need to do that. Because if you don't do it, those reagents are what you will use on your instrument to produce inaccurate results that may lead, in the worst case scenario, to somebody's death. Complete equipment record. It is important, based on this principle number 4, that all documents from when the instrument was brought to you, you need to document it, how it came into the lab, the verification process you carried out, the installation qualification. There's a requirement that from manufacturers that they have installation qualification submitted. If your lab is going to be accredited by the ISO 15189, even if you're not being accredited, you need to have that documentation to guarantee that you are issuing a correct result. You demand it from the manufacturer. Most of it is paid for. Do not use instruments that do not have validation record or FDA or CE approval. They may be high end, but by the time you calculate the cost of quality for using cheap and unvalidated instruments, you find out that it is not worth it at the end of the day, because by the time you calculate total cost of ownership, you find out that you are better off buying that high end that will give you reliable result, because they've done the required validation and human testing that is supposed to be done to certify that those instruments are good and fit for use. So it is a requirement for all testing laboratories to have those records at hand. And if you are to attain or to be assessed on the ISO 15189, you need to have all those documents. You don't throw it away. In my house, once I get the TV out of the box, every other thing, throw it away, because I don't want rats in my house. For the lab, it is very important that you do it. My house is not a lab that is testing results and issuing out results that somebody will use for somebody's life. The lab needs to keep all the documents. Every single information on the instrument, including the manual, must be kept, because if a proper auditor comes to your lab, they are going to check it. Quality control. I know all of us know about quality control. We need to ensure that all the results we are producing are precise and accurate. We need to assess it. We need to implement a quality control plan. We need to participate in an external quality assessment, be it in EQA. There are many of them that are available, even the one that is offered by MLSCN. There is also the one offered by Randox. There's the one offered by Rikers, and there are a lot of them you can participate in. Please, when participating, you also need to take note of the number of persons participating in that kind of external quality assessment, so that you can compare your laboratory appropriately. You need to monitor the performance, trends, shifts to detect if there's any issue, including shifts from from staff. There's also quality control from staff. When a staff starts behaving abnormally, probably they've stayed up 5 nights in a row and they start transferring aggression. We are humans. So you need to have your quality control for your staff as well. Do not overwork them, because by the time you start overworking them, they'll start transferring aggression to your patients, leading to patient dissatisfaction. And before you know it, people are no longer coming to your laboratory for testing. You need to monitor all failed quality testing. Have you established a confidence limit for your quality control results? Does your lab say it is going to accept 3 SD deviations or 2 SD deviations, meaning that 95% of the time the results are within? Based on CLSI guideline, you need to map your tests in the laboratory based on the risk that they can cause to the patient. There are some tests that are very stable and some tests that are erratic, like alkaline phosphatase, like calcium. You run more controls on them as opposed to some type enzymatic creatinine, like urea, like glucose. Those, depending on the method of use or on the instrument, those instruments are very, very stable, and no matter what you do, before you observe any aberration from clinical significance, it is very hard. So for those that can cause harm, like INR, like your cardiac markers, you need to have tighter control and measures on them, as opposed to the ones that don't really cause harm, that are looked like ESR, for instance, that you must put side by side with any other test before they are clinically significant. So you need to look into your lab processes and streamline your tests in order of priority and how they can cause risk to the lab. It is a requirement on control. Do you have a document of how your controls are run? Investigation of failures must be done, and you need to get to the root cause. Ask the question, why did this thing fail? Did I load a new reagent? Why is this person behaving in this manner? This is greater than 2SD, this staff behavior. You need to get to the root cause and solve the problem. And did you document it? It is not that you did a root cause. You need to also document and have a review meeting on these root causes that happen. How are the results released when the QC material is not met? Do you have a way to validate results? Can you run tests that have been done before? Is it documented? Is everybody aware? Risk management is what the ISO 15189 is about. This thing that I am about to do, what are the inherent risks in pre-analytical? From misidentified patient, wrong sample labeling, to entering a wrong result, transcription error, to running a wrong control level or running a wrong sample. Are there risks that you can envisage? This risk management is in the sense that you look at your process from beginning of when the client comes in to when the result is issued. What are the possible risks that are available in the system? Look at it, assess it, then treat the risk. You must not look at it and say, there's this wire on the floor, it can trip somebody, and you overlook it. You need to treat it. Find a way of either stepping into the ground so that it's not raised up, or put in a measure to remove that risk, because if you leave it inadvertently, something adverse may happen. And the worst case scenario is that it may lead to death. After you've treated it, you monitor that that thing that you've used to treat it is effective. It's not just saying, okay, I have a cut, let me put a plaster on it. If you put plaster on it, you did not sterilize the place. I tell you that small cut that you put plaster on will turn into a pus that can cause you to amputate the arm. Same also if a risk in the lab is swept under the carpet. We don't see am, make we just cover am, and you don't monitor it. When the problem will happen, God forbid that it is a relative, and the essence of managing this risk is for continuous improvement, not witch hunting of the scientist or the person that did it. It is not only lab manager's work or QA's work. It is everybody's responsibility to identify risk. And if a risk is reported, do something. Like I always tell my people, if you see something, say something. Don't only stop in saying, because if you stop in saying something, that's just gossiping. You need to do something about it, because if you are living in the glass house, you will not throw stone. You will find a way of protecting your house. When you're passing the market, you will not just throw stone by just saying, this lab safe. Lab manager know they look this thing they happen. That's just wishful gossip. Do something about it. Don't come and complain. Profile solutions. It is not about complaining about the problem. Bring out a process to improve what has happened so that it is better for you, better working environment, and better for the client. Documentation and records can never be overemphasized, because if it is not written, it means it's not done. Your SOPs must be controlled. Accurate and traceable laboratory records. It's not that you will just write it and that's all. It has to be traceable to a generic requirement or a standard operating procedure, or to a manufacturer's requirement, or to a package insert, or even to Monica Chesbro. It has to be traceable. Secure storage of laboratory data. Confidentiality is very important. If you use LIS, do you have a software that will prevent hackers from collecting data and using it to try to trick your patients or collect money from them. A lot of people have been held hostage because of results gotten from the lab. If you use an LIS, who owns the data? Who holds it? Are there mitigating risks? Are there data protection on it? For the ICT person here, they are very important. If you have ICT people in the lab, do they have mitigation risks to prevent people from hacking into your system and selling your results to people? Because a lot of us have information of senior citizens in Nigeria who come for tests, and it can be hacked into at any point of time and the people held hostage. Protection from unauthorized access. If you have computers, does it have user access? For instance, Nkem and Rufus will not have the same access level. Rufus may have a senior level to just edit whatever I do, and I have only access level to enter results. If you have documentation, who is in custody of the manual data that is written? Do you have a safe house, or it is anybody that comes into the lab that can have access to it? Are they stored in a enclosed environment so that unauthorized, for instance, do people have access to your hydrochloric acid? If one staff now snatches another person's boyfriend, do they have access to your flammable cabinet? Do they have access to acid? Because a lot of times, and many things have happened where people who work in the same place want to stab themselves. Do you have security measures to prevent risk from happening? Do you have your defined retention policies? For instance, records generated in the laboratory. Do you have documented time when people can have access to those results? MLSCN in their website have documented guidelines for storage of both specimen and records generated. In principle, there's an acronym that is ALCOA, attributable to who did it, when did it happen, why did it happen. It must be legible, readable. Sometimes you go to laboratories and the ink are finished. They will shake it, and print out results. The result is smudged. It should never happen in the laboratory. It should be clean and permanent and cannot be mutilated, so that any mutilation will be attributed to not being from your laboratory. Because if it is not legible, you cannot write in doctor's cursive writing. Recorded at time of occurrence, it must not be after. You know how we have some laboratory scientists, you have a record sheet, they'll be writing on piece of paper. What have you got a piece of paper? Somebody is saying something. Hello?
Can go ahead, Mr. Kim. I think it's a mistake.
Okay. So I said some people write things on piece of paper and they will write it later. Why not just enter it immediately? Original copy, not photocopy. If for any reason requisition form was carried and smudged with urine, put it in a file jacket, photocopy it, and document on it that original copy was soiled with serum and had to be photocopied, because original copy is always desirable, and you must never rewrite a form, because many a time you may miss an information and the doctor will say, this is not what I sent to you. Always endeavor to keep the original copy, and it must be true reflection of what happened. When you are telling the story of what happened, it must be documented in chronological order, not an afterthought. I thought that I was supposed to. No. State what happened so that the process can be improved. It must be complete, consistent, enduring, and available. If you have an SOP, Everybody that is required to use that SOP must have access to it. It must be consistent. If it is to be used by everybody in your chain of laboratories, they must be using the same version. Not, I have the version of 2025, whereas we're in 2026. No, have a way of controlling it. And for everything that is extinct, you need to archive it and remove it, but still keep a record of it with your quality officer who has access to all the versions. Continuous improvement cannot be overlooked. The essence of all these things is to improve the process by monitoring quality indicators like your turnaround time, rate of rejection. If you notice that a particular hospital, if you're a referral lab, or a particular ward in the hospital is giving you hemolyzed sample, it behooves on you to approach them to tell them that over 3 months now, all the samples we receive from you is hemolyzed. Please, how do you collect these samples so that they don't happen? Because all patients, even patient relatives, don't like, even me as a person, even working in the lab, I don't like you touching my blood. I hate being bled. How much more somebody telling me that they want to collect my sample again? God forbid. It won't happen. If you notice it in a particular ward or a particular person is consistently drawing blood samples that are hemolyzed or very small, training is required for that person or that lab. Information needs to be given to them. Maybe they just employed a new person to come in. We need to investigate, conduct internal audits. It is not enough that you have processes in place. You need to monitor it. As a lab manager, you need to audit your process. Even as a person working as a scientist, you need to audit your process weekly, monthly, so that it is not when quality officer is riding their broom, because they used to call them police or winch, carrying gun to come and shoot them. You need to monitor it, because an unexamined life as a Christian is not a life worth living. Investigate anything that is not normal or an error has occurred. You must investigate, get to the root of it, implement immediate corrective actions, then do a preventive action. You must also do a performance review for your staff, even as a lab, to understand how you are faring with respect to your customer, with respect to your financials, with respect to how you manage people and how you train them. It is a requirement of the ISO 15189. You apply this good laboratory practice in daily work. It is not by just saying it. In the morning, you check your instruments. Do I have all the resources to work on it? Have they been maintained? Are they calibrated properly? These people collecting my specimen, are they identifying those patients with unique identifiers? Do you label your tubes? Do you barcode them? Who inspects all your samples? Those are the small things that can be put to ensure that we are doing the right thing in the laboratory. During the testing process, do you follow your SOPs? I know most of us, we like shortcuts. We use Google Map to find shortcuts, not when in the laboratory. If there's a shortcut that exists, because we are supposed to operate lean system, you have to implement it. Do you document all your steps? Result review and reporting, comparing results against a delta check. If I repeat my test, are they within a specified timeline? Do you notify your doctors when there is a critical result? I've spoken about most of this. Do you do even shift handover? Do you have handover books in your laboratory? You must not finish all the work that comes on your shift. Not that you will not leave a lot of work for the next person coming. What is the handover process? If a person, it must be documented. I'm handing over 12 samples to this person. These 12 samples that I'm handing over, if one person consistently in a shift is handing over work every time, you need to flag that person. Maybe they are not finishing their work. They are passing the buck. You also need to record your errors and put a preventive measure happening. So with all this I've said and Rufus has said today, it's just a sneak peek into our 2026 program. We are going to go in depth into all those requirements. And this is our training plan for the year. And we have tried to come up with a flexible, for us busy people, we don't like leaving our bench work, a flexible timeline. We can have a weekday program, which is 2 to 3 days, or a weekend program, which stays for 2 days, successive Saturdays towards the end of the month. And we'll share the flyer with everybody. And there will be practical implementation. And this is just to ensure that there's audit readiness for everybody. I think we've gone a long, I've taken time in explaining my own. I think I'll stop here. So questions? Precious. Not too much.
Thank you, everyone. Thank you, our facilitators, Mr. Rufus and Madam Kim. Thank you for sharing your knowledge. Thank you, everyone, for engaging. So, do we have questions? We can unmute.
Okay, good morning.
Hello.
Hello, sir. I can hear you, sir.
Good afternoon.
Oh, sorry, good afternoon, rather. My name is Akin Bade from Balm of Gilead Hospital and IVF Center. So
Yes, sir.
we appreciate you
You
for
need
this
to go and
program.
bring all of them out and let them die. Where is the AC coming from? From the off.
Hello, can you hear me, sir?
Yes, sir. We can hear you, sir.
We appreciate you for this program because this program has been a benefit to us, and we are able to see what is going on and where there might be lapses. So my question goes like this: talking about the first the first person that talked, he talked about sample carrying movement. Moving sample from taking sample and moving into the lab. So there's one experience that I got. So that was what will bring about this question. Talking about lithium heparinidine bottle. So I want to ask that how many minutes can sample last for lithium heparinidine bottle before running a test with it? Because that day I noticed that there is a flag in the result, so I have to just go back. I have to just do some background check, and I have to go back and take the sample again before running the test. So I want to ask that how many minutes or maybe hours can a sample lasted in lithium heparin bottle before I can spin it and get my test done? Thank you.
Okay. Lithium heparin is not, you're not allowing it to clot. You're not allowing the sample to clot. Once you collect and you invert, based on the type of tube you are using, you're expected to mix with the anticoagulant. You can actually spin immediately. The maximum time the plasma is supposed to touch is allowed to stay in the cell is 1 hour. After 1 hour, you cannot guarantee that there's no exflux of potassium from the internal of the cell. The sodium and potassium gated ways where there's exflux. Even your glucose will start depleting. So if beyond 1 hour, if you cannot process that sample beyond 1 hour, it is expected that you transfer that specimen into another sample container, label and keep. You cannot even store it in the fridge. You cannot use that sample again. After 1 hour, you can no longer use that specimen. I don't know if it
Okay.
answers your question.
Yes, thank you. But
Hello.
hello.
Yes, sir.
Okay. What happened that day was that the sample was not up to an hour, even not up to 30 minutes. So I centrifuged the sample, and I get my my sample. So because I want to run a fasting blood sugar. Is it fasting blood sugar? Okay, lipid fasting test.
Okay.
Is it
Your
okay?
profile.
No. It's not lipid itself. It's kidney function
Kidney
Kidney
test.
function
function.
Yes, I
test.
could remember.
Yes.
Yes. So when I run the sample, it brought out some indications that there's an error in the sample. So I have to go back to the patient and take the sample. So I run the sample within a minute. I centrifuge it within a minute, and I got an accurate readings.
Okay. So were you the one that collected the specimen the first time?
Yes.
So what was the speed of centrifugation?
Okay, Madam
Uh,
Kim. Sorry. Yeah, Kimbade, sorry, Madam Kim. So, in order not to waste the time for everybody, so Akimbade,
okay.
you're one of our customers, right? So we can actually take this offline and also discuss it. But I also want you to understand that um, the timing for each of these samples are parameter dependent. Okay, so for you can there are some time for this parameter and for other parameters. They are also method dependent also. So it will not be the same time for the same method for a particular method for particular testing, and it can also be different for another method. So that's why it's important that your IFU, that's your instruction for use, is being read before any analysis. And also, like in Kim stated during her session, it should also be documented. It should also be part of your standard operating procedure for documentation. So your case is unique. So we can actually discuss this after this call. You can reach out to us, to me personally. I think I know you personally. We discuss that so that we don't waste everybody's time. Mr. Asna's hand is up. Please, sir, can you ask your question?
Yes. My psychologist hand is up.
Yes, thank you. Good afternoon, ISN.
Yeah, it's Mr. Kola,
Uh,
please.
I think I have been a followers of your program for
Thank
years
you.
now. But I must tell you, this particular one is a classical one. The two presenters did a wonderful job. It's an excellent one. You make me to sit down just to listen from the beginning to the end.
Thank you,
I
sir.
think it's wow. I must commend ISN for this. And again, I've seen your timetable too for the program you have bring on board to really empower and build the capacity of medical lab scientists. I think I'm going to support it. That is good, and that's the way to go. You guys are doing very well. Thank you, ISN, for helping the
Thank
profession. That's just the comment I need to give. Thank you.
Yeah, thank you very much, Mr. Asna. Thank you so much. We appreciate that. And thank you so much.
Thank you, sir.
Cheers.
Mr. Kolade is also raising his hand.
Yeah, Mr. Asna. Mr. Asna Kolade, so he's
Okay,
the
Mr.
lab
Asi.
manager for Asna in Chevron Clinic here.
Okay, Asi Edet.
I see that you can mute here.
Yes, good afternoon.
Good afternoon.
Good afternoon.
Hello, good afternoon, ISN.
We can hear you. Go ahead.
Good afternoon. Good
Okay.
afternoon.
Yes, please, I would like to see the timetable again.
Okay, ma'am.
The precious, you can move to the.
Thank you.
Do we have any other questions? Still waiting.
Any more questions? You can also reach out directly to us through the was your you can also send WhatsApp to the phone number on the WhatsApp questions to the phone number on the flyer for this webinar. I will give any question you ask a some kind of
Yeah.
answer.
Yeah, so even though you can't get it from the fly, you can always reach out to our customer experience team, and so we also always get your queries and also respond to them on time.
Hello.
Precious, you can go ahead, yeah, Mr. Paul.
Yes. Thank you so much, ISN, for putting up this. Madam Kema, I must comment that this is a very, very insightful program that even involves almost all departments in a health and diagnostic center. So what I would like to ask is, are there, aside from the certification that we're going to have now, maybe later after this program, are there any international certification that prepares incoming and existing staff of such kind of organization for best practice?
Yes, there are quite a number of them. ISN, in its own capacity, is also trying to partner with some of those international organizations to bring them closer to the grassroots so that we can become a center for training for those international organizations. But there are many of them abounding. The American Society for Quality has campuses around. The IQS also has training facility for international certification in Nigeria.
Okay, lovely.
I hope it answers the question. Even
Yes.
for ICT people that work in the laboratory, there's also LIS certification training for them, but we do not offer those. You know, we are a diagnostic equipment sales company.
Yes.
Because we've had more than 45 years experience, we've been in operation since 1981. Based on our interaction with our customers, we have deemed it fit that this is what we need to also bring on board so that everyone, for virtue of either associating or buying equipment with us, they have access to what global standard is. Thereby, we are also fulfilling our corporate social responsibility with respect to moving the diagnostic sector forward. For customers that are going to be, we have a program that for customers who are going to be on our preventive maintenance plan, we'll have visits where we'll do audits because we have trained and certified internal auditors who would help them hold their hands and do a gap analysis, give a report. And we can be visiting them per time to ensure that everybody is meeting up to standard. This time around is more like an organization helping you hold your hand for virtue of either buying our preventive maintenance care. It's a package we are rolling out this year. Because you have bought our equipment, and by association, we are adding value in that you are using our equipment correctly, your staff are properly trained, and you have access to international standards. And we are investing heavily in training our scientists because most of our biomedical field application specialists are medical scientists. If we have access to be able to use this, equipment we are selling are from known OEMs whose minimum Six Sigma result production is 3 Sigma, which is global standard requirement for instruments to be used. And because we have these trained people, we are now transferring some of the knowledge we had. In the past, we started it, but we were not consistent. But we have seen that there is a need for this, hence the 2026 program. And this has come to stay. It is going to be a continuum.
Yeah, awesome. Thank you.
Yes. So ISN proud to be your partner for lab automation. So we don't want to just sell you equipment without you maximizing the use of that equipment. So we want to make sure every equipment you buy from us, and you're able to optimize the use of that equipment, and you're able to also make some profit. So we're not just selling you equipment. What we do is that we're partnering with you to make sure your lab is working effectively, can also help you achieve some ISO requirements also, and also, so we're your partners for lab automation. We don't just sell you equipment, we also partner with you. We want to make sure whoever that is making use of these equipment are doing the right thing, and whatever results you're getting are accurate, and your facility is growing while we're also growing also. So that is it. So would also share this calendar with you guys. I think we have, for those that are our customers, we have your email addresses. But if you're not presently our customers presently, you can reach out to us. We'll share the calendar for our trainings with you for this year.
And there's one upcoming on the 28th to 30th, that is weekday, or the 25th, which is a Saturday, and the 2nd of May, which is also another Saturday for people who are too busy during the week and cannot attend. You can reach out to subscribe for this program. We have tried as much as possible to discount it heavily.
Nice. Thank you.
Over to you, Precious.
Yes, for students and intern, you can reach out to the training coordinator. We will consider you for discounts, because we also want our profession to be sustainable. Precious, over to you. I think we don't have any more questions.
We have one from Isaac.
Who's Isaac?
Says for semi-auto analyzer for chemistry analysis, please, which reagent is most stable in sample analysis?
Yes, I can send you the presentation slide. But somebody asked about, that is Isaac. Isaac asked about, for semi-auto analyzer for chemistry analysis, please, which reagent is more stable in sample analysis? It depends. There are a lot of reagents available, and it is beyond the scope of this training. What you can do, you can subscribe to our April series, and you will get to know a lot better about chemistry analyzers and the specified reagents. That is me.
Yes. Yeah, so our April series is talking about clinical chemistry, okay? And share more details about this. I think this is, like Nkema said, is more than our scope for this session. Yeah. Or you can also reach us privately to discuss this also.
For joining, I really appreciate the turnout, and we wish you well in all your endeavors. Until we meet in April, this is us signing out.